I'm Angela Kloepfer-Shapiro. I see patients in Erie at the Buffalo Ridge Internal Medicine Associates Clinic. I've been there for about 9 months, very happy, loving being back home, and love working at Boulder Community Health. So like Wendy said, we're going to be talking tonight about lowering your risk for heart disease and stroke. And I just want to start with this cartoon. I took a few liberties and added a couple of icons, but I just want you to take a look at it. We'll come back to this slide later. How many risk factors for cardiovascular disease can you spot in this cartoon? And it is kind of funny. At the bottom it says, not much, just flushing out my arteries, as this gentleman drinks a glass of wine. So we will come back to that. So if only addressing the #1 cause of global morbidity and mortality was this easy, having a glass of wine while sitting down, that would be great, but it's not. After this talk, you'll be able to list several risk factors that you see here. More importantly, you will be able to list and you'll have a plan for how you can prevent cardiovascular risk in yourself and your loved ones. So let's just start by defining cardiovascular health. You've probably heard the term cardiovascular disease and in a bad way. Let's talk about health. What does that mean? So the American Heart Association defines cardiovascular health as having 7 components. I broke them up into 2 different categories. The first one being health behaviors. So 1, healthy diet. 2, physical activity. 3, abstaining from tobacco, so not using tobacco products, and maintaining a normal body mass index. And we'll talk about all of these in great detail. Those are health behaviors. Health factors, so these are things that, as I'll show you tonight, you can impact with healthy behaviors, but there are other factors that we'll kind of talk about, the nitty-gritty ways they're defined and what they mean for cardiovascular risk. Those include a favorable blood pressure, total cholesterol, and glucose. Okay? So let's just talk quickly about what is atherosclerotic cardiovascular disease. So we talked about health and what that means. What is disease? So it is the leading cause of morbidity and mortality across the globe, okay, so worldwide. In the United States annually, more than $200 billion is spent in healthcare services, medications, and lost productivity. So people not being able to work because of cardiovascular disease, so significant. The leading cause of this is going to be suboptimal prevention and risk factor modification. So what that tells me is we've got a lot of opportunity here to lower risk and really impact everything that we're seeing here, not only death and mortality, but significant costs. What is atherosclerosis? So this slide, you can look at this online. I did borrow this from the Mayo Foundation. This kind of goes into what exactly it is. So beginning in childhood, there are deposits that start forming in your arteries, in everybody's arteries. This is just life, okay? This happens to everybody regardless of what you're doing. Several things can make these deposits grow. We'll review many of those things tonight, and we'll talk about how you can slow that growth or stop that growth. The deposits are mainly made of fats, other cellular material, cholesterol. You'll see later, we're going to talk about how complex these plaques are and really what they're made of. Worst case scenario, what happens is you can see on that third from the bottom circle, you can actually have a piece of that plaque rupture, okay? That jumps off, it hitches a ride on the bloodstream, and it flows downstream until it gets to a place where it's gonna block off blood flow. That's what happens when we talk about a heart attack, when we talk about stroke, when you've really cut off blood flow. So what we want to avoid is getting your atherosclerosis to grow to the point that you're having plaque ruptures and that you're having what we call symptomatic cardiovascular disease or significant cardiovascular disease. So that's what we're talking about in the body and the cells. Let's just talk quickly about diseases that are caused by atherosclerosis, and this impacts your body from head to toe, literally. So coronary artery disease, this is a heart blockage. So you have arteries that supply the blood, the muscles of your heart, and when those block off or become more narrowed because of the plaques, then you have coronary artery disease or heart blockages. Carotid artery disease, so this relates to the arteries that go up into your brain and travel up the sides of your neck. Those are your carotid arteries. Same thing that happens in your heart happens there, essentially limiting blood flow, Worst case scenario, you get one of those plaque ruptures and you block off a piece of, or a bit of artery feeding your brain and your neurons, and that's a stroke. Peripheral artery disease. So this is very important. So this is where you have the same process, impaired blood flow, blockages to other muscles and tissues, and that's any other muscle and tissue. We mainly think of the legs. So you can have this happen in your legs, and it can cause pain and difficulty healing. So lots of problems there. Your stomach, your gut, okay, the arteries that feed your gut can get blocked. Peripheral artery disease is significant as well. Aneurysms. So the atherosclerotic process can cause weakening of the arterial walls. You get bulging of the arteries. That can cause rupture or reduce blood flow. So also significant. Chronic kidney disease. Your kidneys are very, very, very important, and they depend heavily on blood flow. They help blood flow. They help regulate our blood pressure. Chronic kidney disease often occurs when you have chronic lack of blood flow because atherosclerosis, and now you're going to have trouble regulating and getting rid of waste and all of the things that your kidneys do. Again, kidneys, very important. So tonight, so that's kind of the background. Tonight, what we're mainly going to talk about is something called primary prevention and risk factor modification. Some people in the audience may be familiar with secondary prevention, or in other words, they've maybe had a stroke, or maybe they had a mini stroke or a TIA. Maybe they've had a heart attack. Maybe they've been told they have chronic kidney disease. It's going to be a little different, and always talk to your doctor. So everything I'm talking about tonight is primary prevention. A lot of it overlaps, but we're talking about preventing that from happening. Anything I talk about regarding medications or what you should be taking, make sure you always talk to your doctor or your health provider before starting or stopping any medication. So, as mentioned earlier, the American Heart Association had defined those 7 categories. So they have also defined ideal levels for each one of them. No one's perfect. No one can be perfect. There are lots of other factors that impact our body, impact our cardiovascular system. And so really fewer than 5% of people can maintain the ideal measures. So keep that in mind, okay? You can't be perfect, but we can try to get you as close as possible. So that's what we're going to talk about tonight. The best approach is to modify as many of these risk factors as you can to lower your risk of cardiovascular disease. Let's start by talking about diet. So it's funny, I think in this entire slide, or in this entire presentation, I never used the term Mediterranean diet, but that is what I'm talking about here. The Mediterranean diet has been proven to lower cardiovascular risk. You'll see variations of this slide throughout the talk, and it just underscores how important diet is in lowering your cardiovascular risk. So I just wanted to start with this slide. This is what you should eat. Eat these things. Eat a diet high in fruits and vegetables. Fruits and vegetables have folate, potassium, fiber. They have tons of nutrients, but these are some that I wanted to pull out. They have a molecule called flavonoids. You'll see in a few slides. It's also in tea. These are very beneficial. They've been shown to reduce cardiovascular risk on their own. Whole grains. So I say whole grains as opposed to refined grains. The reason we don't like refined grains, that means that the whole grain has been mucked with, and you're losing some of the fiber, you're losing the micronutrients. And so ideally, as little processing as possible should happen to the food that you put into your body. You want to keep it as natural as possible. So whole grains is an example of that. Nuts and legumes. These are high in unsaturated fat, they're high in fiber, and they're high in micronutrients. This includes things like beans and peas and peanuts. They all fall into this category. Seafood, so seafood, salmon. These are rich in long-chain omega-3 fatty acids. Maybe you've heard about that, or fish oil. There is evidence and some data that shows that omega-3 fatty acids can do a lot of things. They can lower your risk for arrhythmia or heart rhythm problems. They can help prevent thrombus or clot formation. They reduce inflammation, and they can help blood pressure. So definitely eat a diet high in these things and you won't go wrong. Prevention through diet modifications, here are the things you should not be eating. So processed meats, deli meats, hot dogs, hamburgers. You really want to avoid anything, again, that's processed. Back to that processed approach, or avoid the processed approach. High consumption of unprocessed red meat. So, steaks and pork and lamb and Some of these other foods that really, they can be delicious. Maybe you don't want to eliminate them completely. Keep it to twice a month if you can. You're really going to see improvement, especially in some of your numbers, cholesterol and blood pressure, if you keep these nice and low. Refined grains, as we talked about, choose the whole grains. Sugar-sweetened beverages. If I could, I would underline this and highlight it and bold it and really just, I can't make this case more strong. Avoid any added sugar, and one of the ways that we get a lot of added sugar is through beverages. That could be a latte, the syrup they use in the latte, that's definitely soda, fruit juices. Watch out for sports drinks, they do have a fair bit of sugar in them. So just because it looks healthy, turn around, look at the sugar content, and try to avoid that. We'll talk more about sugar content later. This kind of is a nice segue. Avoid added sugar. So anything with additional sugar, avoid trans fats, saturated fats. These are the types of fats that you're going to find in really greasy foods. And so you always want to avoid that. Stick with the unsaturated fats, healthy fats found in nuts, avocados, olive oil. Okay, those are the fats you want to optimize. And then sodium. You want to eat a diet low in sodium. As we'll see, sodium impacts blood pressure, and that plays all kinds of havoc on your cardiovascular system. Here are some other categories that often come up. And there's always, keep in mind, there's always going to be a little bit of a moving target as new research is done, and we see what different foods can do. Do they raise our risk, lower our risk? There's a lot of information flying around out there. I wanted to highlight these three things. So dairy. There is a weak correlation that dairy can reduce cardiovascular risk, and ideally, going back to the Mediterranean diet, low-fat dairy is optimal. So if you are going to eat dairy, opt for low fat and not high fat. Coffee and tea. So moderate intake of coffee has shown to reduce cardiovascular risk. Moderate, I think I'd read a number, it was somewhere between 3 to 5 cups. That seems like a lot of coffee. Go with what makes sense. If all you need is 1 cup in the morning, great. It's probably going to help you. You really don't want to exceed much more because simply that's going to cause other problems. It can raise your blood pressure, it can raise your heart rate, but everything in moderation, including coffee. Tea, so the flavonoids, we'd mentioned those earlier, in tea are independently associated with a lower risk of cardiovascular disease. Just watch that caffeine content if you're also having coffee. Alcohol, so this is one that you may get mixed messages sometimes. So let me just caveat this by saying, if you don't already drink alcohol, don't start simply to lower your cardiovascular risk. That's not advised. If you do drink alcohol, especially red wine, there has been some data that shows it can protect or lower your cardiovascular risk. Alcohol comes with a host of other problems, and so you gotta do everything again in moderation. So for women, fewer than 7 drinks per week, standard drinks, that's 5 ounces. For men, fewer than 14 drinks in a week, men over 65, fewer than 7. I think I even saw some recent data that they're lowering that limit for men across the board to 7. So stay tuned for that. You can always ask your doctor about your particular risk. It's a complicated topic, but I wanted to make sure we included that. Let's turn our attention to tobacco. In general, tobacco is something to avoid at all costs. It is the #1 cause of death worldwide. It causes the death of 6 million people across this globe every year. It's not insignificant. The life expectancy is, for people who smoke, is 10 years less than those who don't, all other things being equal. It is something to avoid. Smoking is responsible for about 20% of the cardiovascular deaths in the United States. This is sort of a busy slide, but this shows the effects of tobacco on the cardiovascular system. Just wanted to put this in here so you can see all the different ways that it impacts your cardiovascular system. Can cause heart attacks, can cause problems with your cholesterol. It impacts something called your endothelial layers. It causes endothelial dysfunction. All of that contributes to atherosclerosis and damage and disease to your arteries, increases inflammation. It can cause that little thing up in the right-hand corner, causes arrhythmogenesis or abnormal heart rhythms. It's something to avoid at all costs. Here's the big question, how do you quit? What do we do? Let's first talk about the health benefits, and then we'll get to more strategies. Quitting before 40 will reduce your risk of dying from a smoking-related disease by 90%. So if you're under 40 and you've been smoking, just quit, work closely with your healthcare provider, seek out the help you need, because you can really get that risk right back down, okay? It's not too late. It's never too late. Even stopping after 65, it's not too late. We've shown health benefits and reduced mortality even in people over 70 who stopped smoking. It is never too late. So if you need help, talk to me, talk to your healthcare provider, we can help you. The benefits of stopping start after 1 day. So if you hear my lecture tonight, and you put it away, even if you're having 1 cigarette a day, you're already starting to move the needle on your health tomorrow. The next day, further. The next day, further. Just keep that in mind. Every day, better, okay? How do you do it? Not easy. I know that it's not easy. Combination of medical therapy and counseling has been proven to help. I put the number in here, 1-800-QUIT-NOW. They offer counseling services. I believe they also offer access to nicotine replacement, so you can call them, speak to your doctor, check with your insurance company. Oftentimes they'll offer incentives or assistance with stopping smoking. It is that important. There are medications that can be used, especially if you have a really hard time. You've tried to go off it. You've tried the nicotine replacement and it just isn't quite working. You can talk to your doctor about using a medication to help you get off of it. Varenicline is Chantix, bupropion is Wellbutrin. Talk to your doctor closely about all of those, decide what makes sense for you. The National Cancer Institute does offer a program as well. It's called Smoke-Free Text. I don't know a lot of details about it, but it is available. And if you have any questions about it, please feel free to reach out. So that's my tobacco soapbox. Please just stop and let me help you if you need help. Let's turn our attention now to cholesterol and lipids. So I'm going to use these terms maybe a little interchangeably, lipids and cholesterol. So I made this little diagram to hopefully sort of explain what LDL or bad cholesterol does to our arteries and what it means to start reducing it at any point along the curve, okay? So lipid molecules, they play a central role in developing atherosclerosis and then progressing it into a point where it's more of a symptomatic problem or a significant cardiovascular disease problem. So LDL, these are the low-density lipoproteins. There are a few places in here, I'll call them LDLC. It's the same thing. What these do is they carry lipid molecules and cholesterol molecules all around the body. They just run around in the bloodstream. Over many years, what happens is those low-density lipoproteins, those LDLs, they kind of just settle in. They settle into the walls of your arteries, and they just make a happy little home. Well, it's not that happy because it's atherosclerosis. And what happens, that happens early on. That's part of atherosclerosis and plaque buildup. So what I've made here is some arteries. We've cut them on end. And the first one, we're looking at a 20-year-old. So just a little bit. And let's say that this person, this 20-year-old, arteries that I've made, has an average LDL over the 40 years demonstrated here of 125. Okay, let's just give that person this number. At 20 years, they're going to have a little bit of a plaque buildup. It's not causing any problems. They're certainly not having a stroke or a heart attack. They're not feeling it. They're exercising. They're doing their thing. They're living their life. They don't feel too bad. This starts building up, and over 40 years, or over 20 years, the middle one is the age of 40, now you've got a bigger plaque. And if you see, I've added a little lightning bolt there. That's to indicate inflammation. So now you're starting to pull in some of those other nasty bad actors, those inflammatory molecules. You're starting to make this plaque a little more complicated and a little more nasty. And that's still asymptomatic. So this 40-year-old, they're still exercising, they're not having signs of stroke, they're not having signs of heart attack or angina, but it's growing, it's there. Now they hit 60, and here what we have is increasing risk of cardiovascular disease. That plaque is now becoming more of a bad act, or that atherosclerotic buildup is now becoming something that could become a plaque that can rupture. Maybe they're starting to have symptoms. Maybe they're starting to have aching in their legs when they exercise because they're not getting blood flow to the legs. Maybe they're getting a little bit of chest pain when they really exert themselves. Maybe they're having little episodes of transient ischemic attacks. That's what we mean by symptomatic. So now maybe they're developing actual disease or cardiovascular disease. So what I want to demonstrate here is that the buildup that occurs from these LDL cholesterol molecules depends on how long you're exposed to them and then how much of them are there. So kind of that little equation at the bottom, total plaque burden is equal to the cumulative exposure. So time in years and then absolute volume of LDL. So a little dense there. Let's talk about lowering your cholesterol levels because that's what we're here to talk about tonight. So diet, we've talked about this. Reducing saturated fats, replacing your carbohydrates with unsaturated fats or plant-based protein. Alcohol. Alcohol does play a role in this. This is where we go back to that moderate alcohol might help, but there's a tipping point where it is actually going to increase some of your cholesterol and fat molecules. High fiber foods such as nuts, a plant-based diet, these can reduce that LDL, that bad LDL, if you're eating a high enough diet in these nutrients by about 30 to 40. So that person running around with 125, if they're doing a high fiber diet, they're following all of this advice, they can maybe get that down to 80 or 90. And that's a lot better. It's going to slow the rate of plaque buildup. Very important. So work closely with your diet or your doctor or your healthcare provider to identify a diet that you can adhere to for lowering LDL. That's important as well. Be honest with what your life looks like, what the foods are that you can attain look like, what you can cook, what does your lifestyle, do you have to grab food on the go? Talk about that. The best diet is the one that you can stick with, okay? And again, Mediterranean diet. Exercise. We're going to talk a lot about exercise in a minute. This does have a minor impact on LDL. I wrote minor. I don't want you to think it doesn't have much of one, so you shouldn't do it. I just mean that that's pretty impressive that exercise on its own can lower your LDL levels. So even more of a reason to exercise. Let's talk about medications. So medications to lower your LDL, these are called statins for the most part. There are a few other categories we won't get into tonight, but the first pass are the statins. You may have heard of Lipitor, Zocor, that's atorvastatin, and simvastatin, Crestor, rosuvastatin. These are all the statins. If it ends in statin, that's what it is. They're important for people who are at risk and have worked with their doctor or their provider to determine that they should be on these medications, and we'll talk some about that. They're very important. They play a huge role in reducing cardiovascular risk. They play a huge role in people who've already had, cardiovascular disease, stroke, or heart attack, in preventing it from getting worse and reducing inflammation. So who do we put on these? That's a good question. People with significant plaque or growing plaque benefit from statins. You may say, how do I know? How do I know if I have that? That would basically be, you're probably at the point where you have found, either because you had symptoms, your doctor did additional imaging or other tests that looked at plaque. Maybe you had a coronary artery calcium test and it showed plaque. So there are multiple different ways. A lot of people, especially if we're just trying to prevent it, don't know this. And so we don't add statins just because someone has cholesterol or an LDL level of 120. We're not doing that. I'll tell you how we do decide, and we take into account other risk factors. One quick caveat. There are some people who, even in early adulthood, who don't have the other risk factors that we're talking about tonight. They may be put on a statin if they have a high familial or inherited burden of LDL. Usually this cutoff is about at 190, and that's a pretty high LDL level. It's why testing young adults after the age of 20 at least once to make sure that they don't have an inherited elevated LDL. Those are the people we want to catch and put them on medications early. So what about the rest of everybody else? Then we take into account age, gender, whether or not you have diabetes, whether or not you have high blood pressure, whether or not you smoke. All of these are factors, risk factors, that have been found on population-based data to determine what is a person's 10-year risk of developing a heart attack or stroke. Based on that 10-year risk, we make a decision whether or not statins make sense, okay, and whether they should be started. I've put a link down here. This is the ASCVD risk estimator, and we'll talk a little bit about this later as well. Every person between the ages of 40 and 75 who is seeing their doctor and getting an annual physical exam or wanting to determine what their cardiovascular risk is, I think most docs are using this at this point to determine who should be on a statin. And so that's important. It's kind of a fun little tool to go play with. You can change your risk factors, you can change your age, and just to see what happens in 10 years, all things being equal. If I keep all of my risk factors, what happens as I age? What happens if I was a man and not a woman? Because there is a significant difference. So I guess the takeaway here is work closely with your doctor. The decision to start a statin medication should be one that you don't undertake lightly, but that you do along with your doctor and listen to their advice and try to modify your risk factors as well. Let's talk about high blood pressure, hypertension. So this is the leading risk factor for cardiovascular disease, so pretty significant. Prevalence in the United States is based somewhat on which cutoff you're using. So if you're using the greater than 140/90 cutoff, 32%, or nearly a third of adults in the United States have high blood pressure, not trivial. Now we go to the American College of Cardiology, American Heart Association cutoff for diagnosing hypertension, and now you're at 46% of adults, so quite a bit, nearly half. Diseases that are attributed to hypertension, some we've already talked about, stroke, both hemorrhagic and ischemic. So hemorrhagic is a type of stroke where you have bleeding. Ischemic stroke is one where you have reduced blood flow from atherosclerosis. Heart attacks or ischemic heart disease, heart failure, peripheral artery disease, chronic kidney disease, and importantly, dementia due to small blood vessel disease, which is pretty common. Various causes of hypertension include genetics. Sometimes there is a genetic cause for it, and so it's good to be screened and know what your blood pressure looks like. Diet, high sodium and low potassium can contribute to high blood pressure. Physical inactivity, so not exercising, being obese or overweight, and then social determinants of health. So these are the other things that are not medical factors that we think of that cause elevated blood pressure as listed here, but are part of someone's life. So the stress that they have in their life, maybe access to healthy foods, the jobs, the careers that they're in, all of these can impact and lead to hypertension as well. So measures to reduce blood pressure. I'm starting to sound a little bit like a broken record here, but follow a diet rich in fruits, vegetables, whole grains, nuts, legumes, lean protein, and low-fat dairy products, the Mediterranean diet. The nice thing is it's the same diet for every risk factor, so if you just follow that, you're knocking a lot of them out. Medications when recommended by your healthcare provider. On the next slide, we're going to talk a little bit about what that means. How do you check your blood pressure? What does it mean? What happens when it goes up and down? We'll get there. Moderate aerobic exercise and resistance exercise have both been shown to lower high blood pressure. Aerobic exercise lowers it by 5 to 7 millimeters mercury. So if your blood pressure is sitting at 138, maybe you can lower that to close to 130, 131 just by exercising routinely. Resistance exercise is going to be a little less of a drop, but still significant, and it's still going to be good for you. Weight loss is also going to lower your blood pressure through these means, usually lowering your insulin resistance, lowering inflammation, reducing oxidative stress. We will talk more about weight loss in a little bit here. So let's talk about monitoring blood pressure. So I think it's pretty easy these days to obtain a blood pressure cuff, a blood pressure monitor. When you come into the doctor's office, for the most part, you're going to have a nurse or a medical assistant or sometimes the doctor. Oftentimes I recheck blood pressure if I'm worried about a number that I got. That's going to be the old-fashioned way. You've got the cuff, you pump it up, and you listen with the stethoscope. A lot of times, that's not perfect. Why isn't it perfect? There are a lot of factors. Some people come to the doctor when they're not feeling very well. They haven't been drinking a lot of water or fluids. Maybe they have something going on, and their blood pressure is low. Sometimes people come to the doctors and they're pretty stressed out. That's called white coat hypertension. Maybe you've heard of that. This is why I wear all black every day whenever I go to work, because I don't want to cause white coat hypertension. I want people to feel comfortable. But all joking aside, it's not benign. So even if you say, well, every time I come to the doctor, my blood pressure's high, and it's because I'm stressed and I don't like the doctor and I don't like needles and I'm afraid of what I'm going to hear, That's fine, and that's fine and well. To diagnose this, you really have to also have kind of normal or lower blood pressure, 135/85 outside of the clinic. But here's why this is not benign. If you get stressed out going to the doctor, the rest of your life is not in a vacuum, right? You're having other things that stress you out. Work stresses you out, traffic, maybe you get bad news. Your blood pressure is going to fluctuate. So if you're prone to have high blood pressure in the doctor's office, you're probably having high blood pressure elsewhere, in the rest of your life. And we know that swings in blood pressure can cause problems as well. So it's not totally benign. Masked hypertension is kind of the opposite of that. This is where maybe you love coming to see the doctor and you don't mind because now you've got a half a day off and everything's feeling good and your blood pressure's low and maybe you drink a lot of water a few days before you came in because you wanted to flush out all the toxins and your blood pressure's low. Great. But now when you get out into your real life and you're at work or you're stressed by kids and family and everything else going on, your blood pressure's high. Same thing, you're having swings of blood pressure. So masked hypertension, or let's just call it undiagnosed hypertension, that is associated with a 2 times higher risk of cardiovascular disease. So you're probably asking, well, great, how do I know? That's a good question. Team-based approach is the key here. What I often do with my patients is if I think I'm dealing with maybe masked hypertension or white coat hypertension, or they tell me that, well, sometimes my blood pressure is a little high at King Soopers when I check it, or I checked it at the gym and it was high. To me, that's ding, 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 I get a little nervous. And I say, okay, can you get yourself a blood pressure cuff? We can calibrate it to ours in the office. Check it once a day, maybe once every few days, same time every day. Keep a log, send me the average, or send me the whole log if you'd like through the portal, or you can drop it off in the mail. I don't care how you get it to me, and I'll take a look and see what your average blood pressure looks like. And then we can really make a decision whether or not you need to be on blood pressure medication. So now we'll jump quickly to another risk factor, which is not insignificant, being overweight or having obesity. About 3/4 of adults, 75% of adults in the United States suffer from being overweight or being obese. Let's define it. In general, overweight is BMI greater than 25. BMI means body mass index, and obesity is a BMI of greater than 30. Some of the diagnosis also can be made with waist circumference or waist to hip ratio. You may have heard that when thinking or talking about the metabolic syndrome. And that just implies where do you carry your weight? If you're carrying weight in your abdomen, and what that means is you're carrying a lot of fat in and around your organs, that's a higher risk. So that's a more dangerous type of obesity or being overweight. What causes this? So increased intake of refined carbohydrates and sugars. We talked earlier about sugar-sweetened beverages, one of the biggest causes, along with reduced physical activity. This leads to being overweight and obese. There are some genetic conditions that can predispose. That's a bit beyond the scope of this talk, but for the most part, it's going to be caused by lifestyle factors. Obesity on its own does independently increase the risk for high blood pressure, insulin resistance, which is hyperglycemia, and we'll talk more about diabetes and high blood sugar, high cholesterol, the metabolic syndrome, which is really just another way of saying all the risk factors we've described, and inflammation in the body. What does this mean for the heart, and why does obesity cause extra stress on the heart and cardiovascular risk? So over time, it's going to just by virtue of having to carry around more weight and your heart having to supply blood to more tissue and carry around more, it's going to impact your heart muscle function and structure. Okay, so it's not insignificant. The heart works harder in obesity, and over time this causes strain. Another one that's important to know about is obesity can increase the risk of obstructive sleep apnea, which can put significant strain on your heart. It can actually increase your risk for hypertension, for heart failure, and this is further going to stress your heart. And obesity is one of the big risk factors. So these are the main reasons, in addition to all of the other associated risk factors with obesity, that are going to increase your cardiovascular risk. So here's the big question. All right, great. What do we do about it? How do I lose weight? And that's the biggest question. It's hard to do, especially with our lifestyles and everything going on. How do I eat healthy? What do I do? Let's just talk about kind of the basics. I don't like people to stick to really aggressive elimination diets or really go full tilt into one and then give up after a couple of weeks or months because it's just so hard to maintain, because life gets in the way, because you're going to have a birthday or a wedding or a party, or you're just going to sort of have a bad day, and that's fine. The ideal diet, just like the ideal exercise, is the one that you're going to stick with and that you can do. Let's just keep it simple. Weight loss comes down to a negative energy balance, okay? So you want to expend or burn more calories than you take in. Calories out should be greater than calories in. I tell my patients a lot that, weight is lost in the kitchen, not, on the running track or in the gym. That being said, exercise is incredibly helpful for weight loss if you do it at pretty high levels. To lose weight, you really need to do 225 to 420 minutes a week, which is, not insubstantial and can be hard, especially if you're already struggling with maybe joint problems from being overweight or having obesity. So it's hard, but it's not impossible, and you can build up to that slowly. We will talk about exercise. If you've lost weight and you want to stay that way, or you don't want to gain any more weight, so you're right on the cusp, exercise 200 to 300 minutes per week to prevent weight gain. We'll talk more about what that exercise looks like and how much you should do and what types of exercise. Back to sugar. Reduce sugar intake to no more than 9 teaspoons per day for men and no more than 5 to 6 teaspoons per day for women. That's a very low sugar. I think those are the new guidelines that just came out recently, which was a substantial reduction. I think it's something like fewer than 10% of your daily calories should come from added sugar. Again, there it is. Oh, I did put Mediterranean, the word, in this talk. Mediterranean-based diet. There it is. I knew it would show up. That's what it is. It's the same thing we've been talking about all night. Follow that and exercise. Make sure that you're burning more calories than you're taking in. Let me make a quick kind of hopefully helpful piece of advice for getting there. What I tell my patients, if they want to start losing weight and they really don't know where to start, I tell them to download an app, any app. Maybe it's one you already have. Maybe you have a watch or an activity tracker that can estimate for you how many calories you burn in a day. Get that number. Just get the estimate. It's based on your age. It's based on your height and weight. Get a feel for what that is. And then I want you to take a week or two and just passively record what you eat. Don't change your diet. Just look at what you do. Enter that food in there and the drinks, don't forget the drinks, and add up how many calories you're actually taking in. You got to be really truthful. You don't have to show anyone but yourself. Look at how much you're taking in. Compare that to how much your body is burning, okay? And again, it's an estimate, but it's usually a pretty good estimate. It's your basal calorie burning. That'll give you an idea of whether or not you're taking in more than you're expending. Look for the things, after you log those foods, look for where you could cut 200, 300, 400, 500 calories per day. I'll bet you can find it. I'll bet you'll find it in beverages and little things that you didn't even realize. That would be my biggest advice. Use any app, anyone that can count this for you. Physical activity and exercise. Now let's turn to that because we've been mentioning that quite a bit. So physical inactivity or being sedentary, basically not doing any exercise and not being active, leads to a 20 to 30% increased risk of death compared to those who are physically active. Not trivial. Consequences of physical inactivity, you're probably not surprised to see those top 3. We've been talking about a lot about them tonight, but also cancer and also osteoporosis. Osteoporosis is significant, tends to impact people in their later years, and you can do a lot early on, especially with staying active with aerobic and resistance exercise, preventing the development of osteoporosis. How can it protect your cardiovascular system? So many different ways. Number one, and we're going to talk a little bit about mental health at the end, but it lowers depression, it lowers stress, it increases your social interactions with people, protects your heart from arrhythmias or bad heart rhythms. It can protect you from developing blood clots. The more you move, the more your arteries and your veins are moving blood and they have to respond quickly, the less stagnant that blood's going to become, the less likely you are to develop a blood clot. Increases insulin sensitivity and in turn decreases blood sugar. Lowers your triglycerides. Triglycerides we're not going to go into too much detail about, but they are another cholesterol molecule or fat molecule that can independently increase your risk for cardiovascular disease. Exercise reduces your blood pressure, reduces your fat stores, increases your muscle, decreases inflammation. In general, it just improves blood flow throughout the entire body and to your heart, making your heart a more efficient and more effective muscle and machine, which at the end of the day is what we need. So here's the big question: how and how much and what kind and what on earth should I be doing? So I pulled this little table directly from that link that I gave you earlier from the American College of Cardiology, that risk estimator, that calculator. It's nice. Basically, I want you to focus on the bottom two, moderate and vigorous. The guidelines right now for reducing cardiovascular risk engage in at least 150 minutes per week of moderate exercise. METs, that middle column, don't worry too much about that. That's just a measure of how much energy you're expending and how much workload you're doing. Focus on the examples. Moderate exercise, brisk walking, 2.4 to 4.4 miles an hour. 4 miles an hour is, a 15-minute mile. That's a good brisk walk. Biking, 5 to 9 miles an hour. I guess ballroom dancing, if you can do that right now, maybe not now, but maybe on a YouTube video, you can do it in your living room. Ballroom dancing, any kind of dancing, active yoga, recreational swimming. So this is not even swimming laps. It's just getting out there and swimming, maybe getting your heart rate up a little bit. Vigorous exercise. Now this is where you're jogging, you're running, you're biking kind of fast. Maybe you're playing singles tennis. I don't know why they excluded doubles tennis. I don't play, but maybe, go for singles. It's probably more active. You got to run across more of the court. Swimming laps. So if you can do 75 minutes of vigorous activity a week, great, if that's all you got time for. If you do 150 of moderate, even better. It spends more time being active, doing something for yourself. That's important. Here's the most important thing. Set small goals, choose an activity that you enjoy that is accessible. I'll tell a very quick story, a little anecdote. I try to practice what I preach, but sometimes I don't exercise all the time and I don't really focus on it. And I let other things get in the way. So this summer, my brother and I have a big brother, David, and we got together and we said, we were lamenting that we weren't exercising. So we entered into a pact that we were going to start running 1 mile every day for a year. Didn't matter, rain, snow, heat, and we've done it. We're at day 96, and it's not been easy, but we're doing it. It was a small goal. We do more than that, for the most part. We build up, but it's nice and it's fun. It's fun to have a partner, and again, I enjoy it. It's something to measure. It's something to monitor. It's a little competitive. Choose something like that. Just get started. Just dip your toe in the water, especially if you're swimming. Let's talk about blood sugar quickly. Hyperglycemia leads to prediabetes, leads to type 2 diabetes. Type 2 diabetes leads to a 2 to 3 times increased risk of cardiovascular disease. Throughout this talk, you've seen me mention diabetes and blood sugar. Risk factors for type 2 diabetes clearly overlap with other cardiovascular risk factors. There are new medications for type 2 diabetes that have been shown to lower cardiovascular risk in and of themselves. We'll talk a little bit about that. Hyperglycemia, so high blood sugar, without actually being at the diabetes cutoff, they don't necessarily increase your risk of cardiovascular disease, but it increases your risk of diabetes. And I think, as you've seen in a lot of other places, it contributes to a lot of other risk factors. I won't spend a lot of time on this slide. You can take a look at this at home, you can look at it, talk to your own doctor, look at your recent blood work and see where you fall. Do you have normal blood sugar? A1C measures blood sugar over 3 months. You don't need to be fasting to do an A1C. It's a snapshot of the last 3 months, your average blood sugar. Fasting plasma glucose, you have to be fasting. You measure the blood glucose in the morning, and there are various cutoffs for determining whether or not you've got prediabetes or diabetes. Who do we test for diabetes? Now that's a great question. So we should do it every 3 years for people who have a high blood pressure greater than 135/80, who have a body mass index greater than 30, so who have obesity, or who have known heart disease and/or. How do we manage it? Hemoglobin A1C greater than 6.5, that means that you have a diagnosis of diabetes. Diet changes, go back to that Mediterranean diet, low carb diet. Now you're introducing more of a diabetic diet in there. Exercise, same amounts we talked about a little bit ago. and then metformin is a medication to lower your blood sugar and lower your risk. Okay, now you go 3 months down the road, you recheck it, it's still less than 7, or now it's less than 7, great, keep up the excellent work. Keep checking that level with your doctor every 3 months. If it's more than that, that's when we introduce these new medications, SGLT2 or GLP-1, GLP-1, again, beyond the scope to talk too much about those tonight, but they have been shown to lower the risk of cardiovascular disease if you have type 2 diabetes. Quickly, psychological well-being and cardiovascular disease. We could probably do an entire talk on this. We know that depression, anxiety, anger, PTSD, chronic stress, they can cause cardiovascular disease, so it's a risk factor for developing it. There's new evidence that feeling good, positive psychological well-being, being happy, having optimism, a positive outlook on life, having a sense of purpose, it can actually prospectively promote healthy cardiovascular profile, or it promotes cardiovascular health. This is huge. Positive psychological well-being is associated with lower blood pressure, favorable lipid levels, and lower hemoglobin A1C. It's hard just to tell you to be happy, but work with your doctor, work with your healthcare provider. Being happy can actually help you lower your risk, or not even lower it, but prevent it from getting higher. Take-home messages. Maintain a healthy lifestyle throughout life. Now I've given you tonight all the tools that you need to do that, so hopefully you can. Easier said than done sometimes. Work closely with your doctor. This is the key. Goes along with number 1. Work closely with your doctor or your healthcare provider so they can better understand the non-medical impacts on your cardiovascular health. Make sure they understand what you can reasonably achieve, what you can attain, okay? And make sure they understand those social determinants of your health so that you can work together to do what makes sense. Quit tobacco. I'll just leave that there. Patients 40 to 75 years old should undergo risk estimation with that ASCVD calculator. There's that link for you again. Consume, here it is, the Mediterranean diet, a heart healthy diet. Okay, I won't repeat all those again. If you're overweight or obese, focus on counseling and calorie restriction. I didn't mention that earlier, but dietary counseling, even just psychological counseling, if part of being overweight or obese or part of lifestyle there is impacted by mental health, seek out counseling, talk to your doctor, talk to your healthcare provider, get help for that as well. Exercise, we just talked about that, 150 minutes of moderate, 75 of vigorous. Talked about type 2 diabetes, talk to your doctor about that. Make sure that you're getting screened if you fall into the risk category. Take-home messages, the last page, I swear, almost there. Aspirin therapy for prevention. Only if your 10-year risk is greater than 10%. There's some caveats there. We've really backed off on how much aspirin we're using to prevent stroke and heart disease. And so the most important thing, don't start any medicines until you talk to your doctor. Statin therapy for people with really high LDL cholesterol, or people who have disease or have diabetes and they're between the age of 40 and 75, or people who are at higher risk based on that estimator. Target blood pressure, less than 130/80. So now we go back to our little man here. So how many risk factors? You can probably spot all of them. He's drinking wine, which we've said is maybe beneficial, but I don't know, because he's got a whole bottle there and he looks like he's by himself. That's not moderate intake. He's sitting next to a window, it looks like it's daylight. He should be outside exercising. He's talking on the phone. We don't know that he's complaining. Maybe he'll start to. That's stress. You want to make sure that you have positive relationships. I added the cigarette in his mouth and the sugary drink and the burger sitting next to him. So hopefully you spotted all those and you can think back to this guy and we know and you know now he's not flushing out his arteries as he sits there. And with that, you can see in the slide deck as well, you can go to all the resources that I used here if you want more information. And I'll take some questions.
Thank you so much. Very, very good information. We appreciate it. So a couple questions have come in. I think a few more may start coming here in a moment. And we have just a few minutes left anyway. So how exactly does high stress cause cardiovascular disease? Is it just an increase in, say, adrenaline, or how does that actually cause trouble?
That's a great question. So yeah, several different factors. So stress is going to be one of those social determinants of health. It's sort of a vague term, right? Stress. So one thing it's going to do, and we talked a little bit about it with the masked hypertension or the white coat hypertension, you're raising your blood pressure. You are getting that surge of adrenaline and catecholamine during times when you don't need it. So if your body's surging with these chemicals because you're under stress for reasons that aren't that you're running quickly away from a mountain lion or something like that, now you've just got this increase in heart rate. You've got this increase in blood pressure with kind of nowhere to go. And it keeps your blood vessels stressed, it raises your blood pressure, and as you see over time, high blood pressure, even those surges of blood pressure, can impact your cardiovascular risk. Other things that I think are important to talk about is that it's going to impact just your mood, your overall well-being, increased stress, call it by another name. Maybe that's anxiety, maybe that's depression. Anxiety and depression have been shown on their own to be a cause or risk factor for cardiovascular disease. Higher stress goes along with that. So it's multifactorial, and that's a really good question.
Do statins clear plaque already deposited in arteries in addition to preventing future buildup?
So that's also a very good question. The statins are one of the roles that they play, so we talked about lowering the LDL, and we also, of course, talked about the longitudinal impact of that, where you have the cholesterol buildup over time. So, I want to think of statins as a clot busting or plaque busting medication, but they are going to lower inflammation. There is evidence that statins can lower inflammation. And if you recall that one slide where I had the little lightning bolts and some of the complex aspects to the plaque, statins can lower some of that, okay? So you're going to lower the deposit of the inflammatory molecules, the things that make those plaques bigger, more unstable, and more complicated. And that's one of the main reasons. So it's one reason why we give people who've had a heart attack or a stroke, we give them a really high dose of statin early on, because it does help sort of stabilize, reduce acute inflammation, and make that plaque a little less likely to become a problem. Another great question.
Are there any supplements that you suggest? Perhaps fish oil, or are there any others that you can recommend?
Yeah, a great question. So fish oil as a supplement on its own in the absence of high triglycerides. So we do actually prescribe fish oil for hypertriglyceridemia or high triglycerides because it is shown to reduce it. Taking it in the absence of having high triglycerides, in the same amount that you would get by eating the Mediterranean diet, which has a lot of fish and fatty fish that carries those, the omega-3 or the fatty acids, I wouldn't say don't do it. I don't think that there's been a lot of evidence that it on its own, so just taking a supplement, is going to prevent it, but I don't think it's going to hurt, and in some cases it can lower your triglycerides and some of your other risk factors. In terms of other supplements, that's another thing where working closely with your doctor who has your full set of blood work, do you need calcium, do you need vitamin D, these sorts of things. There aren't any specifically for cardiovascular disease that we would recommend. So like everything, always check with your doctor before you take any supplements. Yeah, I would just check with them before you start anything. And fish oil would probably not hurt.
So can you talk to us about how great eating dark chocolate is?
How eating what?
Dark chocolate is? Do you,
Yeah.
Is it preventative? Can we eat that?
That is a great question. So, and I actually, so thinking back, if caffeine is a little bit protective and maybe some of the flavonoids in tea, I'm going to have to maybe look that up and see what in dark chocolate is good for you. Probably maybe some of the same components that are in caffeine that might be good. The thing with dark chocolate is you want to choose one that's pretty high in the cocoa content, not a lot of sugar, not a lot of fats. And so I think that if you're going to indulge in any dessert, dark chocolate is probably not going to hurt you, and you might enjoy it.
Great. Let's see. Is there any way to reduce the plaque that you already have?
Yeah, so, and that's similar to the first question about the statins. So I can't say for sure if you can really reverse the plaque that's already built up, but you can stabilize it through reducing some of the additional insults that can happen. So short of having, an interventional procedure, which now you're on a different level where they're actually busting up plaque or opening an area of plaque, actually going in there and removing plaque, I don't know that it's been proven that there's anything that can really do that. It's not adding to the existing burden and making sure that you're not making these plaque burdens more unstable and making them so that they become more of a problem.
Can you talk about marijuana? And is that helpful, hurtful?
Yeah, that's a good question. I don't know the data on that, and so I don't want to speak to whether or not it's protective or harmful. I will say that, anything that you inhale, be it marijuana, nicotine, cigarette smoke, is going to be potentially harmful, or definitely harmful in the case of tobacco. Inhaling anything into your lungs, now we're talking about the lungs, not the cardiovascular system. I don't think there's been any studies that say one way or the other what marijuana does to the cardiovascular system, so I probably don't want to give you an answer right off the cuff on that one. But it's a good question, and I think deserves investigation.
Is a heart scan a good preventative maintenance tool?
Yeah, so the coronary artery scan. So I think part of that question is whether or not it's a good preventative maintenance tool. I would look at it as just that. It's a tool. It's not going to prevent you from having anything or progressing unless it shows significant burden in your plaques or in your arteries, that with risk factor modification and lowering your risk, that may actually promote you or sort of convince you like, hey, listen, you've got plaque, you've got this and this artery and that. If that's kind of what you need to sort of make lifestyle changes, yes, that's a great tool. Is it used as part of the recommendation specifically to lower risk? No. That's another scan that I think, or another test, and for people who aren't familiar, it's a type of CAT scan that looks specifically at the arteries around the heart to see whether or not there is plaque buildup. It looks at calcium most specifically, which is part of the complex plaques we talk about. I would say if you're considering getting one, talk to your doctor, talk about your risk factors. There are criteria for who should have one, how often you should have one after you get it, and then what to do with it once you do have one. That's the biggest question. What do we do with this information now?
Great. We have time for a couple of more questions. This is a good question. I think it says, if I work out and I'm in good shape, can I eat more cheeseburgers? It says, seriously, can you work out more and enjoy some of the bad things?
That's a really good question. I would say you're probably just canceling one out and maybe even not even canceling out. So it's hard to say, like, would 150 minutes of exercise a week negate, the burger on Friday night and the cinnamon roll and the donut on Sunday morning? Is it going to cancel it out? Possibly, and then you've kind of wasted your exercise. Or are they not going to cancel each other out, and now all you've done is just added to your risk by eating? I don't think we know that for sure. And in general, what I would say is everything in moderation. I think everyone, if you want to cheat occasionally and have the things that you enjoy or you want to indulge, do it. Keep it to once or twice a month. But I wouldn't look at it as a trade-off to do one and the other at the same time.
All righty, we have one more question.
Sure.
What is the difference between hard and soft plaque?
Hard and soft plaque. Yeah, it's a good question. So I think probably the distinction here would be plaque that is more stable and kind of dug in. So a hard plaque would be something that's heavily calcified. It's maybe been there for a while. It's probably complex, but it's also pretty stable. Soft plaque, and again, I probably would want my cardiovascular colleagues to answer this, but probably going to be one that's more heavy in platelets, thrombus, other types of clotting material and I'll just say blockage material that is going to be riskier and more prone to growing more quickly and clotting and maybe rupturing. So I would probably defer to my cardiovascular colleagues to true me up on that one. But, yeah. Thank you.
Wonderful.
Thank you.
Doctor, thank you so much for your time and expertise tonight. We really learned a lot and appreciate it very much. And we have come to the end of our time. A recording of tonight's lecture will be available at bch.org/livestream. You'll also receive a post-lecture survey by email tomorrow. Please take a moment to fill out that survey and return it. The hospital is very interested in your feedback on these lectures, and so we just thank you very much for joining us tonight, and please have a nice night. Thank you so much, and bye now.